So welcome. It's good to see you. Any declarations of interest, first of all? No. Okay, that's fine. Any apologies for absence? Shirley?
We've got Barbara isn't on, and neither is Claire or Neil at the moment.
Right, we're just waiting for Claire and Neil to join. They're definitely joining. Barbara may be a few minutes late. Okay, well, we can carry on doing the core stuff anyway. Minutes of the meeting held on the 7th of January. Any comments on accuracy there? Can I assume a silence means people are happy with those? Right, I will do then, thank you. Matters arising from the action log. Shirley, anything you want to add on that? Okay, go on.
No, we can't get the speakers to. Right. Okay. Need to switch yours off. So all the actions are green, are not yet due. Dave will update us on 17/805.
Thank you, Shirley. So I've been taking rather a liberty with this. My plan was to bring back an updated paper on HSMR to next board, and within that it will pick up these aspects. So I thought there was little point bringing a paper to this board to say I'm going to bring a paper back to next board, if that makes sense. Is that acceptable, Chair?
Yeah, that's fine. Anything else from anyone? Any other comments? No? Okay, thank you, Shirley. I'm not going to say very much on my. Have we got feedback here?
No, I switched off.
Well, we'll see. Hopefully, it'll go away in a minute. I'm not going to say anything else on my report. I think it's fairly self-explanatory. But I'm happy to take any comments from people or observations from people. Anyone got any queries or comments? Okay, thank you. Richard.
Good morning, everyone. Lovely to see you virtually. I hope you're all safe at the moment. So as in previous months, I will divide the Chief Exec update into two. One, first part focusing on COVID, the second part non-COVID factors. So in a moment, Simon will give a situational update on the organisation, and then Claire will give an update around our vaccination programme. It's clear that despite a slight reduction in the rates of COVID in the community and the organisation, our three hospitals remain very busy. Our thoughts and gratitude are with everyone across the public service who's been involved in caring for patients over the last year. I just checked this morning. I think I'm right in saying the first patient with COVID at Sherwood was diagnosed on the 14th of March. So we've had COVID and patients with COVID in the organisation for the last 326 days, very nearly a year, although for many respects it feels far longer than that. And so far, very sadly, 457 people have passed away at Sherwood with COVID, but more positively, 1,131 people have been discharged. As I said, huge recognition and gratitude for everybody who's been involved in patient care and the support of patient care. And inevitably, and we might touch on this in the SOF, I think a lot of the sort of the national reporting around COVID and the thinking quite often is dictated by the position in London. We know that the third peak was seen in London 2 or 3 weeks before the third peak in the Midlands, and London are moving into a calmer process. Inevitably, that means that a lot of the conversation now is focusing on sort of life post-COVID and restarting services. And I think we all share the view that it's unrealistic to expect the group of people who have been actively involved in COVID care for over a year now to switch and fully restart normal non-COVID care immediately. I think we are proud of the welfare and well-being that we've put in place. And I think the best thing that we can collectively do to ensure that we deliver sustained progress in terms of bringing back our different pathways is ensuring that we build a pragmatic plan based on what is possible and with the welfare of colleagues at the centre of it. So before I touch on non-COVID things, I'll hand over to Simon and then to Claire, please.
Thanks, Richard. And just to pick up on your point there, it's been positive to see in this second surge that 10% more patients have been discharged from the hospital than in the first surge. So clearly some of the treatment is working around these patients. So we currently got 166 inpatients in the hospitals that are COVID positive. This is from a high of about 208, so we're seeing a fall in position, but it still remains very high and almost double what we saw in spring 2020. We've got 20 patients currently in critical care. To put that into context, our normal critical care capacity is 9, and the COVID positive cases doubled between Christmas and New Year, so a very steep increase. So even though we've got a falling position, the levels remain really high, and the levels of infection in the communities remain really high as well. So it's causing quite a great deal of pressure across the organisation. There's about between a 9 and 10% staff absence rate, although we have seen some decrease in this week, but there's a natural variation within that. All our surge capacity is open. So we've got 62 extra acute beds available to medicine at the moment, and we've actually now opened 24 more beds than the winter plan that came to board, and that's been funded via COVID funding. I think our oxygen supply is being well managed. The incident control team get daily positions on the oxygen delivery and usage, and we have contingency plans in with triggers to move patients where required. That plan has been implemented at times, but not in the past few weeks. So that's positive, and I think that is being managed very well by colleagues on the wards and within estates. And then finally, just a bit of sort of a non-COVID business. So outpatients continues to operate at about 80% of pre-pandemic levels. So we are maintaining outpatients. Quite a lot of those appointments are virtual or by telephone, but some of them are face-to-face. And that is defined by what the clinicians feel is the best approach to those individual appointments. Elective operating is broadly running as normal at Newark, but is around 40% at Kings Mill, and that is mainly due to the significant critical care surge, which obviously covers the geography of theatres and use quite a lot of the anaesthetists and theatre staff to support critical care with the safe care of those patients. That's all I really wanted to say, Richard. I'll hand back to you.
Thanks, Simon. Claire Teeney.
Hi, morning everybody. So by way of an update on the vaccination programme, as a Nottingham and Nottinghamshire system, the vaccination programme is progressing well, and we've now got all of our local vaccination sites and centres open and up and running. In terms of the progress for us at Kings Mill as a hospital hub, we were one of the first sites nationally to start vaccinating on the 8th of December. And I think it's fair to say that the vaccination hub has gone from strength to strength. We've been supporting the vaccination programme broadly in terms of the priority cohorts of people to be vaccinated. So that's those over 80, over 70, the clinically extremely vulnerable and health and care workers, and we've been participating heavily in that. In terms of our throughput within the hospital hub, when we started vaccinating, we were doing circa 100 vaccinations a day. We can now manage up to anything about around 800 a day through the hospital hub. And we were one of the very few national pilots that participated in the 24/7 programme. And we did that and opened up last month for a 24-hour period over a couple of days, and we've fed back the learning around that programme. In terms of our own staff, we've vaccinated over 60% of Sherwood colleagues, and within that, those staff that are shielding, we've vaccinated again over 60%. For colleagues that are over the age of 60, 74% of those colleagues have received the vaccination, and for our BME colleagues over 50%. We're continuing to do some targeted work around those vaccinations for our own colleagues, and we are opening and extending some of the hours in which we operate the vaccination centre to ensure that our colleagues can access that vaccination. I'll pause there. Thank you.
Thanks, Claire. Thanks, Simon. So colleagues will remember, members of the public will remember that throughout certainly the last 3 to 4 months of our response to COVID, we've focused as an organisation on delivering 3 things in conjunction with partners. The first bit is about ensuring that we are caring for all patients, not just being a COVID only service. And as Simon described, we're making progress on that, and that will be referenced in the SOF. The second point was ensuring that we are looking after others as well as ourselves, and I've referenced I think we should feel proud about the work that we've been doing around welfare and well-being, although we do recognise the cumulative impact that the last year would have had on people in their working and their personal lives, and I think that needs to continue to be a focus for the organisation as nationally we move into some form of recovery over the months and years ahead. And then the final bit is about being proud about the many, despite the huge challenges we face, the many successes that have happened in this organisation. And Claire referenced, we were actually the first organisation in the country to do 24/7 vaccination, which is, I think, good recognition for the organisation, and also recognition that in the eyes of the national and regional regulators, we're seen as an organisation that they can depend upon. Just before I go onto non-COVID things, Chair, maybe I should pause there and see if there's any questions about that.
I'm just looking at they're not on the chat. Other than what I've said, I don't know if we know this. Are we going to find out what the sort of vaccination levels for the population of Mid-Knots are, as opposed to the population of Nottingham as a whole? Because obviously that's more wider, the vaccinations there.
Claire?
Yeah, so I can comment on that, John. We will get into the space of being able to receive that information in due course. It is all being worked through. We haven't got the absolute detail at the moment, only the overarching numbers through all of the vaccination centres across the county. Over the next couple of weeks or so, I expect that will be broken down and refined, so we'll be able to report on that in more detail.
Okay, thank you. I can't see any other questions there, so Richard, do you want to continue?
Yes, just building on what Claire said, when we have the information, we will certainly share it. The way I view our response to vaccination is we have a primary and a secondary responsibility, and I think our primary responsibility is the points that Claire was describing there, and however you cut the workforce at Sherwood or across Notts Healthcare or the local authority against the groups of minority ethnics, over 70, shielding, etc. We've made huge progress. And then certainly in terms of that, the secondary factor about working in conjunction with partners to sustainably roll the first dose, and then in the next couple of weeks the second dose out across Mid-Knots. We have made progress, and I think the numbers when they're available will support that. Just a final comment is I think it's quite interesting. We've been looking at our role as an anchor organisation. Colleagues will remember some of the conversations about this, and we've been looking at actually mapping the locations in which colleagues at Sherwood live compared to levels of deprivation. And unsurprisingly, given deprivation across Ashfield, Mansfield and Newark, quite a high proportion of our colleagues live in areas that are defined as more deprived than others. And the fact, therefore, that we are rolling out the vaccination programme effectively, I think suggests that is part of an important levelling up agenda. Moving on to non-COVID issues, clearly, the organisation remains very busy with lots of other things going on. I've touched in here around the work we're doing around bullying and harassment. We don't want to overemphasise this, as we describe it really is only a minority of visitors, patients and members of the public, but we have seen a small number of people behaving in a way that is not in line with the organisational values, and we've actively been involved in making that clear, as I think we describe also. Julie and I have written to a couple of people, yellow carding them from the organisation. Congratulations to Cora, who last month won the election for the co-chair of the East Midlands Black and Asian Minority Ethnic Network of the British Medical Association. That's fantastic for Cora and for Sherwood. I wanted to take the opportunity to recognise that this month is the LGBT plus History Month, and we were delighted, a number of us, to see a couple of days ago that we have finally been able to get the flagpole outside Kingsmill Hospital on the Mansfield, on the Morrison's side working, and if you drove in to the organisation over the last week or so, you'll see that the rainbow flag there is flying with pride. Penultimate point is, I think we referenced from memory last month in our public board about the initial information from the NHS staff survey. Emma and her team have been doing some more analysis of it, and it came through the People and Culture Committee in January. The initial findings are really positive. People will remember that over the last 4 to 5 years we've made improvements year on year, and we have certainly, despite a position of sort of relative strength last year, we've made fantastic improvement over the last 12 months that we're quite excited about. We believe that because of COVID, the release of the national data set has been delayed, so it's likely now to come out in March rather than February. And then finally, we've taken the decision over the last month. The Director for Infection Prevention and Control, that portfolio, for historical reasons, was sat with the medical director, and as part of looking at portfolios, Dave and Julie have been having a conversation about that, and the action's been taken for the portfolio of the DIPSI to transfer from Dave to Julie, which I think makes sense, and I'm grateful to both of them for that. Happy to answer any questions.
Okay, again, I can't see any questions in the chat box, so shall we move on then to maternity incidents and the maternity perinatal quality surveillance model? Julie.
Thank you. So I'll take the incident report first, if that's okay. So there were 95 maternity incidents in December. All of those were low or no harm, except for 2 that were moderate harm. One of them was a congenital abnormality that wasn't diagnosed antenatally. I think it's important to say about this one, the abnormality that the baby had is commonly missed, so not unusual that it wasn't picked up on ultrasound. The second was an unexpected term admission to the neonatal unit, and both incidents are under review. We've signed off one STICE report that we mentioned in the report last month, and this is the maternal death, where the lady is suspected to have died of a pulmonary embolism, but we're still waiting for the post-mortem results to confirm that. There were 3 incidents that went for scoping in December. One was a maternity unit closure, and we do scope all maternity unit closures because of the impact that it has on women and their families. There was a term admission following an emergency caesarean section, and that meets the HSIB requirement for external investigation, so that has been referred on. And the final one that we've commissioned an internal investigation into is an antenatal intrauterine fetal death that was secondary to an abruption, so probably not predictable, but there are concerns that this baby was small for gestational age, and there may have been opportunities to identify that at an earlier point. I'm happy to take any questions on those. You'll see the outcomes of those reports in future months, but overall a stable month within maternity.
Any comments? I can't see anything. Can I just ask one then, Julie? There's a lot of what you've termed incidents, but a lot of them are sort of events which, when you start looking at them, actually they're because it didn't follow the absolutely expected route, but didn't have any harm, etc.
Yeah.
which is good because it means people are reporting things and raising issues, which is great. I just wondered, do we have any comparative figures about whether we're seeing a higher level in other places or a lower level? Or I mean, you've highlighted the 2 or 3 that's slightly more serious and what's happening with those, and that's good. But I'm just wondering, is it normal, given that you can't predict how birth's going to go perfectly, to have a lot of incidents, of which a large number of them are just, this didn't quite follow the normal courses of events? Or actually, are we seeing a higher level of those here than elsewhere?
So there's a list of triggers that are defined nationally for incident reporting, so we follow those. And we do get a quarterly report by the governance team that shows us whether there is any under or over reporting, so we can incorporate that into the next report. I am confident that there's no under reporting, and our scorecards don't suggest, other than the highlight reports we've included,
Yep.
That there are any areas of concern.
Because I mean, that's one of the things the board has to take some judgment on is, medicine is a risky, there are risks and there are things that happen, but actually, which of those are really serious and which of those you would expect, what level you might just expect in the normal run of things. So it'd be useful to have some comparative on that, just to give some sort of feel to the board about that. Yeah, thank you.
Sure.
Any other comments on that?
Neil's got a question.
Neil?
Yeah, thanks, John. Just wanted to ask Julie if we have any idea why we've got a higher than expected rate of hemorrhage. It seems to be in a fairly consistent trend across the year.
Yeah, so the team have reviewed all of the hemorrhages and can't find any themes that would be considered avoidable within this cohort of women that have had a major hemorrhage. About 50% of them have an emergency caesarean section. We know you're more likely to have a major hemorrhage if you've had an emergency section, because the womb has done all the work of labour and then has to clamp down once the baby's been delivered. We also have a population that have more babies. And there are some risk factors around deprivation that mean that you're more likely to have a postpartum hemorrhage as well. But the team continue to look at this to make sure there are no themes in the management of those PPHs that mean that we could have reduced the blood loss.
Okay, thanks.
All right.
Manjeet and then Richard. Manjeet?
I think Manjeet's is on the next report that I'm going to present.
Okay, fine. All right, we'll pick that up then. Richard, did you want to ask something?
Yes, it's a similar but slightly different point to the one that you raised, John. Sorry, Chair. So, Julie, you've been in the organisation for 13 months now. You've got a background as a midwife, strong reputation for this. Obviously, any harm is incredibly sad, but based on your assessment of the first 13 months, are there things about our maternity services that worry you?
There's nothing that keeps me awake at night. I think we have seen, so we've had 2 maternal deaths this year, and I think we have to take any maternal death really seriously. Having said that, that is a national trend that we've seen with COVID, and we know that both of the women that sadly died following care with us had pulmonary embolisms, and we know that that is has been attributed to the COVID pandemic, whether women have actually had COVID or just associated with people being less active postnatally. So I think the 2 maternal deaths would be the bit that I worry about, but our investigations into them haven't found significant findings. But I think we always need to be vigilant around that.
Thank you.
Okay, thanks. No more questions on that first. So Julie, on to the second report.
Yep, so you've got the quality surveillance tool. There are 3 exception reports to highlight to you. So Neil's already mentioned the major hemorrhage. The next one is around training. So our multi-professional training programme was suspended for much of this year because it requires quite large numbers of the multi-professional team to get together and do simulation in an environment, and with the social distancing this hasn't been achieved. We have now made it partially e-learning, and the rest we will do in situ on the lay ward. So at the moment we are we're at 15%, but we've got a clear trajectory to embed that over the next 6 months. And the final exception to raise is a CQC inquiry that we received. and that was in relation to our CTG training package. We've submitted all the evidence in relation to that inquiry and have heard nothing further.
Okay, thanks, Julie. Magic, you had a question, I think, on this.
It's on the last one, I think.
Yes, it's on the second report.
Right, yeah.
Shall I go on to that one?
Okay, yeah, go on to that one. Sorry, yeah. Yep.
So this last report you saw last month, which is our implementation of the Ockenden findings, and last month we reported partial compliance with the independent advocate role and the consultant presence on the labour ward.
Yep.
We took our submission to the local maternity and neonatal system, and more information has become available nationally since our submission, because the deadline was extended shortly after we brought it to board. We're now going to declare not compliant with 2 further measures, and the first one is the Director of Midwifery. We had believed that the RCM guidance stating that smaller units don't need a Director of Midwifery remained true, and actually they're saying nationally that's not the case anymore. So we are declaring non-compliance with the Director of Midwifery post, but noting that I am a registered midwife with exec responsibility for midwifery. And then the final point is around the consultant midwife. So we have appointed a consultant midwife. She starts on the 15th of February, but we can't really say that that role has been implemented as yet. So we're declaring partial compliance with that. So it's for board sign off before we submit externally.
Okay. Is the Director of Midwifery a change then in the requirements?
It is, because we declared compliance last time because we thought we were excluded because we're a unit under 3,500 births.
Right. Okay. Thank you. Majid, yeah.
Yes, Julie, thank you. My question was around the partial on the training, and it really was, is this mandatory training, and are we full on the mandatory training? I just wanted to understand a little bit more on that partial.
Okay, on the prompt simulation training. So this is new to Sherwood. I think it's fair to say lots of units have been doing multi-professional simulation training for some time, but Sherwood chose to implement this in the middle of last year. So we're partially compliant because actually all of our teams haven't been through it yet, and this is the first document that is saying we have to do it.
Right, so would we designate that as mandatory training, you know, when we're seeking assurance on our training? Okay.
We will designate it as mandatory, yeah.
Okay, thank you, Julie. Thank you, John.
So it seems to be, correct me if I'm wrong, there's a number of things which have either been made mandatory or have been specifically required coming out of the Ockenden report, that because 2 or 3 things you said seem to be changes from what might have been in place 3 or 4 months ago. Is that fair?
That's fair, yeah.
Okay, so I can't see any other questions. So thank you for the work on that. I think it provides quite a lot of assurance, and I think if we can just get a feel for, you know, where we sit with others, given the different type of incidents, etc., that would be really helpful. Yeah, good. Thank you very much.
Thank you.
Okay, Shirley, I think we're on to you.
Thank you, John. I'm taking the Freedom to Speak Up report because unfortunately Epsana can't join us today. So it's there for you as read. I'll take it as read. There's been 52 concerns raised this year up to the end of January, which is lower than previous years. That's sort of in line with national trends. Things are lower this year. However, 26 of those concerns are COVID related, and the detail of that is in the report. Epsana's doing lots of work proactively on the back of COVID within maternity and respiratory. The idea was for Epsana to go out to those. Obviously she can't do that, so she's doing all those meetings on Teams, but we are being proactive, and Epsana is going into there. There is a new learning package, e-learning package, and that will be coming out to all leaders within the trust, and that'll be a comms and a launch around that. And then Afsana's having early conversations with the NGO. It's about the regional equality and inclusion strategy, and there are discussions about how freedom to speak up becomes a wider system role as opposed to a secondary trust role. So unless there are any questions, I think it's just a brief report and just a brief update. If there are any questions?
Can't see any in the box.
Okay, thank you.
Okay. Thank you very much. I'll put it to some. Right, thank you very much. Can we move on then to the staff and board assurance framework? Thank you.
Sorry, Chair. It's Richard here. I was slow to type. Can you hear me?
Yeah, I can hear you. Yeah.
Can I just go back to the Freedom to Speak Up report?
Yes, of course. Yeah, sorry, Richard.
Apologies. Yeah. I was typing, but not quite quickly enough for the cut-off. Shirley, do you think we're making satisfactory improvement with Freedom to Speak Up?
Sorry, Richard, I missed that.
Sorry. Do you think we are making satisfactory improvement with Freedom to Speak Up?
I think we are bearing in mind the restrictions of this last year. I think Afsana's been really good in going out and being proactive in going to areas where we know we were challenged. And I think we're not out with, our concerns aren't out with any others. So yes, concerns have gone down, but that's a national trend.
Thank you.
Thank you.
Okay, thank you. Thanks, Richard and Shirley. Can we move on to the nurse staffing board assurance work? Julie?
Thank you. So this is an update that the regional team, NHS Improvement, NHS England, have asked us to bring here. It gives you an update on what we're doing around nursing and midwifery staffing to attract and retain staff, and there are a number of actions that we have continued throughout the pandemic, and then what we're doing to minimise the workforce loss. There's also a checklist which was published as a guide for chief nurses to ensure that we are making sure that nursing and midwifery staffing is as safe as it can be. You can see that we've made good progress on a lot of these. The position has changed since this was submitted to board. So since it was submitted to board, our super surge plans for critical care have been signed off, and the move to a ratio of 1 to 3 where required, and our QIAs have also been submitted. It's likely that there will be a national version of this document, so we will continue to work through this, but I think it's likely we'll be bringing back a different version of this in subsequent months. Happy to take any questions.
Claire?
Thanks very much, John. Just wondering how you feel that nursing staff who perhaps have been in some of the high intense areas around COVID, what the long-term impact of that will be upon their desire perhaps to stay in nursing or to stay in that acute environment, and what work are we doing in terms of projections of what else we might need to do to fill those gaps in addition to what we already know?
Thank you. Gosh, difficult question. We had a good meeting yesterday with the respiratory ward leaders, and I think it's fair to say that they are all feeling it. And we've put lots of support in around psychology, coaching, just making sure that people's fundamentals needs are met whilst they're at work. We haven't seen an increase in turnover in the last year, and I think it's quite difficult to predict how many people will choose to leave Sherwood. What we are focusing on and making sure that we've got a strong pipeline that includes growing our own through the traditional routes that Sherwood has adopted through student nurses and midwives, but more recently the implementation of the trainee nurse associate role again, because we've had a pause in that for about 3 years here, and we also have the registered nurse apprenticeship starting again in September, and we're beginning to look at new roles and how we can augment the workforce with different roles across nursing and medicine. I think predicting how many will leave Sherwood is perhaps a question I can take away, because I'm not sure we have any baseline data to help us with that, but there is an opportunity to use some of the national surveys that are out there.
Okay, thanks. Dave, you I think wanted to come in on Claire's question.
Yes, thank you, Chair. If that's all right, Claire, that's a really interesting question. There's starting to be produced a number of papers about the impact. Obviously, it's taken a while to develop this. There's some good papers coming out of Birmingham just showing some of the enormous erosion that this is likely to do to our workforce in terms of retention and probably recruitment. The National Clinical Director for Critical Care, Kevin Fong, is starting to do some bespoke visiting to critical care units, particularly to try and pick up some of this work. And the data to date is suggesting that the incidence of post-traumatic stress in the personnel working within critical care is running at 3 times what was seen from military personnel returning from the front line in Afghanistan. I think those are really powerful statistics, and obviously there's a huge national focus on this, with HE starting to galvanize what we might do about all of this, but this will run and run, I think.
Thanks, Dave. Claire, was yours a comment on this same question? Claire Tini?
Yes, please, if I could, Chair. So to support what colleagues have already said, and to reiterate Julie's point really about the support that we're putting in the here and now to support colleagues with what's going on, and as part of our onward retention strategy. What I would also say is that what we have seen is that the pandemic is having an impact in a number of ways. And one of those ways is also in raising the profile of some of the healthcare opportunities that there are. And we are seeing a lot more activity in terms of people interested in working in healthcare. And indeed, that's the way that they want to take their career. So I wouldn't want us to lose sight of that aspect as well in terms of our pipeline, which actually looks encouraging and helpful.
Okay, thanks, Claire. Sorry, Barbara, you've been waiting a bit. Coming back to you.
Thanks very much indeed. So, Julie, this may well link to what you've just been saying, but I wanted to ask, out of all of the things you've covered in the paper, what is it that you're most worried about?
It's got to be critical care super surge, because we have a plan. We're reliant on some temporary staffing to fulfil that plan to get to 30 beds. We're much busier than we were in wave 1. With wave 1, we could pull from our wards because we had circa 200 empty beds, and I think our super surge plan will get us there, but it's tight. Okay. So that would be my biggest worry, and go into a ratio of 1 to 3, which I really don't want to do, but we have agreed it if we need to.
Thank you for that clarity. Thanks.
Thanks. I can't see any more questions, so thank you very much.
John, sorry, I had a question. I think it got missed in the chat.
Oh, sorry. Okay, yeah.
It's Manjeet, apologies. I'm first of all, apologies, my camera's not working. I wanted to say, Julie, it was a really helpful and comprehensive report, and you know, a range of interventions. However, our band 5 is still quite high, and I wondered if we could have a deeper dive in a report to the People Committee around what more we could do, and around the areas of recruitment and reducing the numbers leaving and the training.
Yeah, absolutely. We fare pretty well, if I'm honest, on our vacancy rate, but that 100 is the magic number, I would say. Yeah. So yeah, very happy to.
And I also wanted to add, it would be useful to understand with the global COVID pandemic, what the impact may be on some of the international recruitment that we rely upon as well.
So at the moment, there is a big push nationally. So we've received a huge amount of funding to support our international recruitment programme. And we are continuing to get nurses through. So we had 9 arrive in December. We've got another 9 coming in February. So it's probably a little bit slower than it was, but there is a lot of support nationally to bring nurses into the country. and we always recruit ethically from a Sherwood perspective. So we recruit from countries where they train nurses for export to support the economy locally, just to cover that.
Thank you.
Thanks.
Okay, thank you very much. I think that's all the questions. And thanks for that, Julie, really helpful. You've been a bit busy over the last 2 or 3 items, so thank you. If we can then move on then to the single oversight framework, the performance report. Richard.
Thank you. So the soft covers month 9, December, and also quarter 3. We're going to go through the normal order. So people and OD, quality, access, and then money. And based on previous conversations, we're going to be very specific with our contribution. So we're looking for 3 points for each of the 4 domains, please. Can the first one hand over to Claire and Emma? Thank you.
Thank you very much. Thank you, Richard. Thank you, Chair. I shall take the paper as read. There's 3 key things I'd like to pull out for this month's board and to make people aware. One is relating to the significant work that we've been doing over the last number of weeks with increasing rest areas for colleagues, and what that means is providing spaces, safe spaces, and also areas where people can take a break, rest and refuel and rehydrate. That in addition to actually ensuring provision of hot food and how they access that hot food. Some teams and services really struggle to leave their areas at times. So it's about how do we get that to teams and to colleagues to ensure that they have that time. So there's a lot of focus around rest areas and ensuring that they take a break and refuel. The other key thing I'd like to highlight is the work around wellbeing, particularly with regards going to areas. I think it's fair to say we've had quite an increasing number of requests for support in clinical and non-clinical teams, and also with regards line management support for those colleagues who are helping others in their team. And that really anchors back to our taking care of self and taking care of others. To date, we've probably undertaken around 30 road shows in the last couple of months. We've got at least another 15 planned this month, and nearly 20 to be booked in. So I think it's brilliant, and I think we should be actually pleased that our colleagues are turning for this support, but we're certainly seeing an increase in that, and feedback has been very positive in terms of just providing that help, that guidance, and someone to talk to, and importantly signposting them to the support that we have got in place for them and their teams. So that's been something key for us. And the third area I'd like to raise is regards You Said Together We Did. And this is particularly based on the learning from COVID that we did in the autumn of 2020, and the actions that we took away from that as an organisation. And I'm pleased to say we've progressed many of the things that colleagues said we could do to help improve that Sherwood is a place to work and the care that we provide for patients. And some of that includes with regards, Richard's already referred to, around bullying, harassment, violence and aggression, and our position as an organisation to support colleagues. Other things also include recognising improvement and keeping that energy and morale going by engaging colleagues in the things that they have done, but also the things that they want to do. And we'll be launching an ideas generator with our colleagues in this month. And again, that's just about bringing some positivity in this current climate. So those are the 3 things that I really wanted to highlight. Happy to take any questions. If not, then I'll hand over to Claire. Thank you very much.
I can't see any questions. Can I just ask one? And it relates a little bit, I think, to some of the discussion we had in the previous item, which was my experience is that people go through difficult times, and it's very important we support them. But actually, it's when they come out of them that they also need support, because people then relax a bit, etc. Are we doing some work around thinking about, well, what happens what extra support do people need when we get to the stage of starting to come out? Because I think at that stage we mustn't assume that staff are going to be fine. I think some of them may find that's when the reality of what they've been through will really hit them, I think.
Yes, of course, it's a good point and a good question. So as part of the wellbeing roadshows where we've been going to areas and discussing with line managers, we've been identifying the here and now, but also what we've been doing is responding to some of the new needs of colleagues. For example, things like parental support, actually being able to come to work, but also with the situations around schools and managing childcare and teaching from home, and also where colleagues are having to work additional hours. So we've worked closely with Notts Healthcare and the child psychology team to look at putting on specific bespoke sessions to help colleagues in terms of parental support, or if they've got any troubles or concerns with regards to their children. And that is about actually allowing them to come to work to be the whole self without worrying and the guilt that they feel from that. Claire and I are also, as part of the people plan, but also the forward view, looking at that longer term health and wellbeing offer, and that is about the recovery of our people. So some of it is with regards, some of it we don't know yet, but we can predict what will be coming, and I think that psychological and post-traumatic stress support is in the key offer now and will be going forward.
Okay, thanks, Claire.
Thanks, John. Thanks, Emma. Just to follow on with a couple of points, if I can. So, in terms of the absence rate overall, that's continued to be high and reached its peak at about 10%, which is, over double what we would normally expect through this period. And the overall impact has been around COVID, either people off with COVID symptoms and COVID itself, and or isolating associated with that. In terms of how that benchmarks nationally, with the national figures are seeing increases overall of 10 to 12% workforce loss. So that puts us in that space and is consistent with elsewhere, albeit not a nice figure to have to report on. In terms of the things that we're doing to support our staff health and wellbeing around that, Emma's touched on those. To support that, we're also putting in the interventions from the Occupational Health Service, and the activity around occupational health remains high. Just to build on the point you were asking about, John, in terms of your question there, Occupational Health Service here at Sherwood has never had any dedicated clinical psychology support working within it, and we have funded that particular support, which will be dedicated to working with colleagues within the organisation around those clinical psychological interventions, and also picking up on the points that you've raised about how we support staff with maybe some of the after effects of the pandemic, and particularly from a psychological perspective, and ensuring that we're able to refer them on to the relevant and appropriate services. And we are doing that work within the organisation, but also at a system level. So we will have access to a system resilience hub for mental health and wellbeing as a partner at an ICS level, and the services of that resilience hub will be able to be accessed by our colleagues to support their overall psychological health and wellbeing, which will be good. And that's particularly targeted at some of the after effects in terms of the medium and long term around COVID. A couple of other things that we're doing to support the health and wellbeing, as we've said, the vaccination programme, so over 25,000 vaccinations going through the hospital hub, and the update, just to reiterate, for Sherwood Forest colleagues is over 60%. And we also continue to roll out and support lateral flow testing, which does enable the early identification and potentially of COVID, and enables people either to be off work and or be in work if they haven't got a positive test result. The final point from me is around another vaccination, and that's the flu vaccination programme and uptake, which does draw to its natural conclusion at the end of this month. And overall, year on year, we've improved our flu uptake, and we've got currently, in terms of frontline staff, 88, nearly 89% of colleagues that have accessed the flu vaccination. We are having a final push on that this month, just to cover that off. I'll pause there in case there's any questions.
Well, it's brilliant on the flu, isn't it? You're almost there at 90%, which is what you set off, so well done. Manjeet, I think, first, and then Tim. Manjeet, I think you're on mute.
Yeah, sorry, I was trying to unmute. It takes a while. I was going to say, my comment was really in terms of looking at everything. Sometimes the RAG rating can show a red on things, but in terms of safety and well-being of our staff and patients, I just wanted to particularly make a comment on the appraisals mandatory training that in between these surges, it has been good to see the appraisals rising and the mandatory training rising. And if you look at the graphs, it is within the range. So I just wanted to make a comment on that in terms of assurance.
Thank you. That's good. Tim.
Thank you, John, and everybody. John, it's a little bit of a crossover from Emma and Claire around the support for our staff and well-being and everything else. I think that COVID hopefully will give us an opportunity to look at what it is we put in place for COVID, but also how we continue that once we've got through all this, whether that be end of this year or whenever it is. But also, is there anybody nationally doing anything on this? Because working in the NHS and in certain areas is quite traumatic anyway. So I think some of this could be business as usual rather than as an exception due to COVID.
Do you want to comment before me, or either or?
Yeah, if I just so yes, Tim, thanks for that. There is a lot of work that's happening nationally, regionally, system-wide, and within the organisation, and actually it's really encouraging to see that for once a lot of that is joining up quite well. So an example that I gave there was about the Nottinghamshire Resilience Hub, which will be something that it is piloted, but I do think will continue. And the Wellbeing Hub for Nottinghamshire comes on the back of an idea of something that happened after the Manchester bombings, which was really about a resilience hub for victims of those that had experienced the bombing and their families to be able to access the relevant psychological support and interventions. And on the back of that programme, there are a number that are being set up across the country, and we will have one here in Nottinghamshire. And that is based on that learning, but also in terms of some of what we've found through COVID and being able to put in some ongoing support that we embed into the system so that staff can access that. And the earlier that they can access the support, we know that actually the better the outcomes and the better the prevention is around that. So that's just one example of how some of what we're doing is already taking shape, which is encouraging.
I think, if I may, I'll also add to that. Thank you, Claire. I think there's also, Tim, a very clear directive through the NHS People Plan, which is very much focused around actually ensuring that our colleagues are safe and healthy, and that all links back to health and well-being, and those are things like ensuring that every organisation has well-being conversations in place, has a well-being guardian, and that actually we ensure that we support colleagues from both a physical and mental health perspective, and that is really going to be a very key focus around the NHS People Promise, and that is, you know, our continued aspiration and ambition to ensure that we respond to that for our colleagues and for our patients. So I would say yes, it's very much nationally recognised and regionally, and certainly by us in Sherwood going forward. Thank you.
Thanks, everybody. John, I think from my point of view and from us as the board is that some of these will come through some of the work that our charitable support happens, but there will be also financial implications. So we don't want things to be just from people above us who monitor and regulate how we use finances to say you can't be doing this. This is why I was asking from a national point of view. We need our chairs and CEOs nationally to keep this high on an agenda.
Yep. I think the other bit, which is very much part of the wider debate, is how we support some of the ethnic minorities, and making sure we're doing that as well as we can, taking into account the fact that they are often the ones who suffer more, or have done in the past, more likely to get severely ill, etc. And that in how we think about how we're going to support the staff now, but also into the future, is we need to take some of the learning that's come out of a lot of the national and regional work on this, and make sure we're embedding that in how we do things as well. Okay, thanks for that. Richard, back to you.
Thanks. Just before I hand over to Dave and then Julie for the quality, just picking up on that last conversation, I think it's important we recognise, I think we've received £112,000 from the Sir Captain Tom Moore Legacy Fund. Fantastic amount of money. I think it was about 30 million raised nationally, and that money's been spent predominantly, as you'd expect, on supporting the welfare and well-being of colleagues. So things like some of the wobble rooms across our 3 sites, staff rest areas. We've spoken in public before about the hardship fund, some specific supported intensive care. So thank you to everyone involved in that. And I think that ties back to that previous point of the conversation. So moving over on to quality, safety, patient experience. Dave, and then Julie, please.
Thank you. Julie and I are going to do a tag team, and we thought we'd highlight C. diff, seal, some of the healthcare associated COVID infections, and then around complaints. So I'll just start around the C. diff rate. So as you can see from the SOF, we've had 25 cases. It's really difficult to pick the trend, I think, with this. Just looking at the graphs, what I would say is that this is broadly similar to last year. In terms of the assurance, so the antibiotic treatment, all of these as C. diff cases go through a root cause analysis. The antibiotic treatment has been appropriate, with no patients being on antibiotics longer than necessary, according to these root cause analysis. All of these cases get discussed at a C. difficile weekly meeting, where we have representation from infection control, microbiology, and also from gastroenterology. And obviously key to this is also our pharmacy involvement, and the antimicrobial pharmacist ensures the timelines and the antibiotic usage is appropriate in all of these cases. I think what I would say is that as always, there's work we can do on this, and I think we can get better at ensuring that actually as soon as we possibly can, we get appropriate samples into the laboratory, and that would significantly help us differentiate between trust acquired cases of C. diff or community acquired cases of C. diff. And then the other aspect in terms of C. diff is we've had a relatively small number, but it's a small group of what we might call reinfected cases, so patients that we've had as in hospital and then we've readmitted, who've then tested positive, and I think there's more work that we can do on this, and just perhaps investigate that further. So I might just stop there on C. diff before I go on to healthcare associated COVID infection.
Any comments specifically? I know Graham and Neil have got questions, but if it's not specifically on C. diff, we'll pick it up later. Any particular points on those, questions on those? No, I don't think so, Dave. So
okay, thank you. So in terms of the healthcare associated COVID infections, so we actively continue to monitor the outbreaks. You'll see the cases described there in the SOF, and for me this is a reflection of the activity that's going on in the organisation. I think there's a whole host of external assurance we can take from our work. The outbreak, the weekly outbreak or the twice weekly outbreak meetings are attended by PHE, by CCG colleagues, and and the CQC has an open invitation to attend this, and we are assured that we are appropriately dealing with these cases at the moment, and we've seen a reduction in that over the last few weeks. There have also been a number of reviews that we've had as an organisation. So we've had the CQC have undertaken an in-depth review of our any outbreaks and of our healthcare associated prevention processes. We've had the health and safety executive who've come and done an assessment, and we've been involved in the HSIB report that was published in October about COVID-19 transmission in hospital. So a significant amount of external insurance. As I say, always more to do. We have ensured that now, relatively recently, we've put all of our patients into masks where we're able to, despite the social distancing that we have between our beds. But we're trying to ensure that our patients, particularly those that are more mobile, are wearing masks. We've been much tighter on our visitor policy in terms of asking them to wear masks, and that brings its own challenges, and we may touch on that later. I think the other aspect I'd say about these COVID infections is we've started to now look at the data and what the impact on our length of stay is. So actually, what does that do for our patients who are acquiring COVID within our organisation? And I have a proposal in development about putting some medical director office resource into examining the impact in a more longer term, particularly those patients who die within our organisation for this, and also those that perhaps survive with the more longer term outcomes and impacts. So that will be coming back. I can update about that. So I'll probably stop there and take any questions on COVID, healthcare associated infections, before I pass to Julie.
Any specific questions on COVID, or okay, Julie, and then we'll pick up Graham and Neil's comment after questions after that. Julie.
Okay, thanks very much. So I was just going to pick up patient experience. So from a complaints perspective, we had 60 complaints in Q3, which is an increase for Sherwood, but we benchmark well compared with others. Key themes amongst the complaints is around communication, so whether that's about the care and treatment plan or the discharge plan, and this has coincided with the restricted visiting that we brought in back in December. In response to that, we've launched the Family Liaison Service, and some of you will know about that, which have been supporting it. We've also activated the bedside telephones so that family members can contact the patient directly. We've got a discharge improvement programme headed up by the head of ops, and we're doing lots of work around the carer's passport to ensure that carers are part of a patient's care while they are an inpatient. From a FFT perspective, a lot of the results are driven by the response rates, and that's because nationally FFT has been paused. We've continued it here, but we are a bit hamstrung with the methods by which we can get feedback because of the infection prevention and control measures around sharing iPads and bits of paper. So we are reliant on the text service. That's all I'd like to say on that, so happy to take any questions.
Okay, Graham, you've got a question, yep.
Thanks, John, and thanks, Julie. Just wanted to pick up on the patient safety incidents, because although you rightly make reference to a sign of open and transparent culture, the number per month has steadily increased and more than doubled over the last 9 months, and that feels just a little bit more than a little bit more open and transparency, and if there were any underlying concerns we should be aware of.
Yeah, Dave, do you want me to answer this, or do you want to come in?
Sorry, go ahead, Julie.
So I think we have seen the benchmark in here previously when this was flagged that showed that actually we don't have any under-reporting or particular areas of over-reporting. I think the thing I would say is that we've got significantly more beds open over the last 8 weeks, which means we have got a lot more patients in the building, and we are also supporting the vaccination hubs, which will account for some of that incident reporting that we're seeing here as well. There's nothing that none of the themes that I can think of that I'm concerned around, and we are collating all of the COVID harms. I don't know, do you want to come in, Dave?
Yeah, so that was really the point I was going to make. So I take this as a positive step, and I know, Graham, there's that difficulty about when you stop being positive and when you start being oh crikey. But very similar to the freedom to speak up Guardian, the more that we see of this, the better that is, because then we can pick up those themes or try and understand what is going on. So as Julie says, nothing that concerns me. I have very actively tried to capture COVID related harms, and that's a whole industry now that we have running alongside this. So I'm pleased that this is going up and not surprised.
Thanks, Dave. That's helpful, because when you look at the trend line, it does worry you a little bit, but I understand the explanation. Thank you.
I think it might be useful for as we get this data coming through in the future, just for the quality committee, just to have a look at it, because I think you put it very well, David. You know, what stage is this actually good, people reporting things, and at what stage do you say, oh crikey, is there something here? So I think it'd be useful for just to be a conversation at the quality committee around that. Is that okay? Thank you.
Absolutely, thank you.
Neil.
Yeah, thanks, John. I just wanted to ask about AHPs. I don't think I've ever seen that we've had any problems before with AHPs, but apparently the staffing is now becoming increasingly challenging. I just wanted to understand whether this is down to COVID or vaccination support, or whether there's something more structural that we need to address from a recruitment point of view.
Thank you. So our vacancy rate amongst AHPs remains low. But we have got some hotspots where we have small numbers of AHPs working in areas. So an area that comes to mind for me is dietetics. So we have a small team of dietitians here. We've got one on long-term sick and another one that's left, and the agency supply is not good. We've also had some sickness issues across radiology and occupational therapy. So I don't think it is a widespread vacancy concern. It is around workforce loss, and then some of those services that are quite small to begin with, and the loss of 2 is felt very widely.
Okay, thanks.
Kate and Carl have secured quite a lot of money from the ICS, so they are looking at placement capacity for the future and career pathways, and thinking about how we attract more BAME AHPs into Sherwood as well, because that population nationally is much whiter than the nursing and midwifery population. So there is some good work going on there, and we'll update on that in the biannual staffing report, which will be coming in the next couple of months.
Thanks, Julie.
Thanks, Julie.
Claire? Yes,
thanks very much. I just wanted to ask, follow up a little bit on the cardiac arrest issue. I obviously thinking that some of this might be COVID related, but also some of it might be consequences of COVID. So what sort of things are we able to do in terms of making sure that out in the community we're encouraging people not to delay on signs, because I assume that this is a part of the consequence of seeing such a steep rise in cardiac arrests.
Shall I start that, Julie? So we've highlighted this over the past 2 or 3 months. Some of this is around actually capturing the data within the cardiac arrests. Before prior to 2 or 3 months ago, we weren't capturing cardiac arrests across the whole organisation, so we weren't specifically capturing ED cardiac arrests or ICU cardiac arrests. Those are because they're managed in-house, and what we were capturing was cardiac arrests where the cardiac arrest team was called, if that makes sense, because it was being captured by the resuscitation team. So we tried to get a wider breadth of this, so that's partly related to this increase in number, and the SOF, because the SOF is the numbers historically delivered, so we've got to rebase that, and we will do that as we get to the next iteration of this. I think there's a subtler point in that about the role of the resuscitation team in cardiac arrest and how we do that. At the moment, it's very much an educational based resource. I think there's a desire across the MD and then chief nurse office to make that more of a hands-on approach, but we're still working through that detail. In terms of, are we seeing more preventable cardiac arrests? No. We are, particularly with COVID, we're very much more involved in having conversations with patients about what matters to them and what we should be doing with them. We know that the outcome from cardiac arrest and COVID is absolutely frightful. And as you say, we ensure that we've had those discussions beforehand about appropriate escalation, and then that those patients are escalated beforehand if appropriate. Does that answer that, Claire? And Julie, did you want to add anything to that?
No, thank you. I think you've captured it.
That's helpful. Thanks very much, Dave.
Okay, thanks. I can't see anything more on quality questions, so Richard, back to you.
Over to you for access, Simon.
Thanks, Richard. I'll just start on emergency care, a few key points around that. So emergency care remains strong, ranked 8th in the NHS during December, and our ambulance handover was the best in the EMAS area. So very strong emergency care performance. That says it has deteriorated a little bit. That's largely due to bed accessibility. There's a really strong correlation between the number of COVID positive inpatients you've got and bed accessibility, because the sort of bed processing time and turnover takes a lot more time due to infection control and oxygen supply and cleaning, so it takes longer to create beds through the day. Staffing levels on the wards, as we reported earlier, have been more challenged as well due to COVID absences, and therefore there's a longer duration through the day for discharge jobs to get on. And then we've also seen a bit of a growth in the medically safe for transfer group of patients. Again, pretty COVID related, in high numbers of nursing homes have been closed due to outbreaks, and then social care are also experiencing staffing absence issues with due to COVID isolation. So I think emergency care performance remains strong relatively, and it but it has been more challenged mainly around bed accessibility. So I'll pause there on emergency care and take any questions if there are any.
I can't see any on that. Just one from me. You talk about emergency care, sorry, bed access, but we've actually got quite a low occupancy compared to plan. So I just wonder, how does that sort of relate to?
Yeah, so that's some of the things that I described, Chairman, around the occupancy can be lower, but 90% occupancy when you've got high levels of a transmissible infection are different to 90% occupancy when you haven't, and that's largely due to that occupancy is suppressed by a bed being emptier for longer. Because of all the moves that have to take place on the wards, the side room reviews and moving throughout side rooms and the cleaning of those areas. So I think that beds are inaccessible for a longer period of time in hours for all those reasons. So that tends to suppress the occupancy. What we should see is, as COVID falls, or hopefully falls, that occupancy sort of normalises itself, and then you see better flow through those bed spaces.
Okay, thank you.
Just a brief point on cancer. I think the cancer service overall is back at pre-pandemic levels and is delivering sort of pre-pandemic waiting times, which is you know, not at the 85% target, but back in between 70 and 75%, and the tail of that, the tail of that waiting list in terms of patients who are waiting longer periods is at a more normal level. Our average weights and our 85th percentile weights for cancer treatment are at pre-pandemic levels as well. So I think that there's more work to do in that area to sort of, we knew we had work to do to improve that before the pandemic, and that work still stands and is mainly around the time to diagnosis. But you'll also see that the faster diagnosis standard, we're doing better than plan on that. So I think we are making progress in that area. So I'm relatively comfortable with where we are around cancer care, particularly given the pandemic. Anything on cancer? No. And then,
sorry, Simon, I just think we should note, you know, it was a real concern of ours, wasn't it, coming into wave 2, and I just think we should thank the staff who've been able to sort of keep the cancer service going far more than in the first wave. So, because actually the performance, I think, does look quite good, and certainly compared to other organisations, I think you've done a really good piece of work. So thank you very much, sir.
Yeah, thank you. And Julie and Dave have a clear role to play in that as well, because what we've tried to do is, in redeployment of colleagues to areas like critical care, we've really tried to protect the cancer areas from having to move colleagues to work in critical care. So it's been a real team effort. I'll just move on to the waiting list. So the waiting list is broadly stable at between 35 and 36,000. Obviously, it saw a huge growth after the pause last spring, and obviously it's not come down from that period. Everyone on the inpatient waiting list has got a priority score, which a clinician has identified for them between 1 and 4. So we're clear on the clinical risk across the inpatient workload. Newark continues to sort of operate as broadly a green site and is doing quite a lot of operations there. But at Kingsmill, as I said earlier, we're doing 40% of our sort of like 2019 workload, and that is very focused on patients who are priority 1s and priority 2s who've largely got cancer or other more serious issues. So I'm confident we've got a good system there for managing the clinical risk around that. And Helen Hendley, my deputy, chairs a prioritisation group which has a clinician from every specialty, and they all agree who goes on to which theatre lists that are available over the coming week. Outpatients is trickier around that, so we're doing more work in outpatients. We're doing 80% of our 2019 activity, but out, you know, there's tens of thousands of patients on the outpatient waiting list, and it's harder to give them all a priority score. So clinicians are continuing to review those lists and bring patients forward who they may think is at risk in those areas. We're also using the independent sector where possible. We do have nearly 600 patients waiting over 52 weeks, and we are seeing some growth in that. Whilst we're in this period where we're only doing 40% of operating. But again, those patients, clinicians are reviewing those patients and making sure that we're getting the sort of patients who are the highest priority in earliest.
Any comments? Can't see any there, I think. Okay, thank you very much, Richard.
Thanks, Chairman.
Thank you, and over to you, Paul, for money.
Thank you. So 3 key things in terms of the quarter end. The deficit recorded against the available resources to us in the COVID financial regime leads us to a deficit of 2.2 million in that period, which happens to be the year-to-date figure as well, and that is $500,000 better than we thought we would be when we submitted the phase 3 plan. This includes COVID spend for the year, to date of 16.2 million. As I noted with the board last month, NHS-EI continue to work with the Nottinghamshire ICS to consider revisions to the year-end position in respect of the phase 3 plan. And we have agreed a year-end position, which means that our forecast year-end position of 6.8 million can be achieved within the available resources, and that this would be acceptable to NHS-EI, and therefore have accepted this. What this leaves with, this is a credible position, but there is a residual risk of increased COVID costs if the current if the current depth of COVID surge continues to the end of March. And clearly we're seeing some subsidence of the peak that we experienced at the end of January. In terms of capital, year-to-date spend is 7.91 million, which is 460 more than the plan that we signed off at the start of the year, and it's adverse to plan because we've started to spend those additional discrete project funded elements of the plan that we're not in the plan but are now being pursued, which is the expansion to emergency department as just an example of those projects. And in terms of cash, our closing cash at the end of Q3, our cash holding is 36.5 million, which represents the prepayment of the January block contract income and a continued improvement in creditor payments and better payment practice code. Happy to take questions.
I can't see any questions. Okay, so that's the SOF, I think, isn't it, Richard? Can I just make us over? I just think that with all the pressures going on, I think this is a very good performance. I'm particularly pleased that we've managed to keep some services going like cancer, etc. I think that we've seemed to be controlling the money. We recognise there's huge pressure on staff, and I think we've been trying to do a lot there. So I'd just like to thank the exec team, but also the wider organisation, because I think there's this is a very good report that's come through at an extremely difficult time. And the last 2 months or so have been, well, you have to turn on the telly to see how difficult it's been. I've also been lucky enough to spend a little bit of time on some of the wards over the last couple of weeks, and actually, while they're clearly very, very busy, there's also a sense of calmness there and control. So I just, I think on behalf of the board, I'd like to pass our thanks on for all the huge amount of work that's gone. Thank you very much. Richard, did you want to say anything before we move on?
No, thank you, Chair. I agree with that. I'd tie that back to the point we were discussing right at the beginning of board about the importance for us to continue to sort of systematically focus on the welfare and the well-being of colleagues, because that's going to be essential. Clearly, across the wider NHS, there's going to be lots of pressure now with the sort of the view that COVID is beginning to drop off in communities, and that will be an indicator of where we will be in hospitals and in critical care for the next couple of months. And there'll be a big expectation that we then sort of recalibrate very quickly and not only build on the good work of cancer, but continue to bring in the day case, the inpatient, the outpatient work. And I think we at Sherwood and elsewhere, we're united that we need to, where possible, carve out the opportunity for people to have a meaningful break. And that's more than just having a couple of days off. And we've got to balance the need of the individual who work at Sherwood along with the need of the individual patients. And I think what we're going to do, Chair, is we've got a board session in March where we're going to take the opportunity as the execs to take the non-execs through some of the planning and the feasibility about what may be possible. We know that last year, as we exited wave one, there was some clear understanding about, from a national perspective, where they wanted organisations to get to, and broadly speaking, we were able to achieve that. There's been no such guidance yet. That may come down, but as you and I were discussing earlier, I would urge us within the organisation to identify what we truly think we can do in terms of access, whilst maintaining safe care within the financial agreements and focusing on the welfare and the well-being, and then tying that back to the national ask.
Well, thank you. This is an active conversation at the national level as well. I know, with making sure that people understand at the national level what the how we balance, or think carefully about how we balance trying to recover from treat people quickly with the fact that staff have had a very hard time. So thank you for that. Okay, shall we move on to the next item then? And the next item, the board assurance framework. Shirley, is this you?
It's me.
Richard,
so
sorry.
It's okay. The Board of Assurance Framework last came to the Board of Directors on the 5th of November. You can see where we are in terms of the key risks of the organisation. Within the report, it details the various committees, whether it's the Quality Committee, the People, Culture and Improvement Committee, Finance Committee or Risk Committee, where they have been discussed since the 5th of November. A couple of changes are proposed in the document. We went through them in the last Risk Committee. So the table on the front page of the BAF containing a summary of each principal risk, and then the removal of the risk treatment strategy field in each principal risk, because that does not provide any meaningful information on reflection. So I think those two changes make sense. And as you can see, one of the key themes that's been running throughout board today is the impact of the combined threats of COVID and winter pressures, and they are certainly present in the BAF. What we haven't done on reflection is touch today on the EU exit. The last couple of boards we've touched at the beginning on the impact on the organisation, or the planning in advance of the EU exit and the impact. And the reason why we haven't touched on that is because it appears that the country and Sherwood has successfully exited the European Union. It's not impacting on the services or the provision of the kit and the equipment that we need. So very happy to answer any questions.
Can't see any questions on that. So thank you for that, Richard. Thank you. Shall we go on to the assurance reports from the assurance committees? The audit and assurance committee, Graham.
Thanks, John. I'll take the report as read and take any questions, but just to add a couple of bits in there, particularly around internal audit. As would be expected under the current circumstances, getting all the pieces of work on internal audit completed is a challenge. We're doing all that we can to try and facilitate and help that process. The really important thing is to make sure we get enough of those reports completed to enable the head of internal audit opinion to come through. At the moment, that's okay, but we do need to be aware of that. One area where we're a little bit behind, to say the least, about implementing recommendations is around the DOL's Mental Health Capacity Act recommendations. That's being picked up at the moment by Quality Committee to actually look and see how that's progressing. If there are any issues that arise from that, we'll pick it up again in audit. The other bit to raise is around the register of interests. We are doing well, but I'd still like to see us do better. The timing's not right to really put pressure on consultants, etc. So we're going to pick this up, particularly in April, as we start the new year, and especially to target those that haven't completed a declaration of interest for one or more of the last couple of years, of which we haven't got too many, but we do have a few. Happy to take any questions.
Again, I can't see any.
John, could I? So
sorry, Dave. Yeah.
Just to build on that. So in terms of the consultants, we're going to add this as a component of the appraisal process, which we hope will strengthen that for us as an organisation and the audit and assurance committee.
Thanks very much, Dave.
Okay, finance committee, Neil.
Yeah, thanks, John. Again, I'll take the report as read. Just wanted to add just a couple of things, really. First of all, just to say that the planning for next year has been delayed again. We did expect to have something from the regulators by the end of this financial year, but sadly that's not going to be received now until April next year, with the plans due to be submitted by June, by June this year. So that's sort of slightly disappointing. The other point to make is really just building on the point that Paul made about cash. We do have a significant cash balance at the moment, and the payment for March is going to be reduced by 29 million. But that will still put us in a sound position by the end of the financial year, although there may be a small shortage of cash in April, but we have had assurance that we will get cash to fund that period if we need to. So happy to take any questions.
Any questions? Again, I think I can't see any. So thank you, Neil. The Quality Committee, Barbara.
Thanks, Chair. Again, take the report as read. 4 issues just to flag up to the board. The first is we had a good debate around the impact or potential risks associated with the PFI contract, and we gained significant assurance from that. We're delighted that we've been able to benchmark using some of the skills and expertise from one of the London hospitals on their assessment of our risks. So that was a really good agenda item. As mentioned earlier, we've made great progress with cancer services, and we received the annual report on cancer services, and there's a lot that's been learnt over the last year and extending into the COVID period about how services are delivered virtually as well as in person, as you might imagine with COVID going on. And I'm also pleased to report that we have now had our JAG accreditation reinstated. And just to remind colleagues, this was suspended for a number of months. This is to do with endoscopy services, and it's because we've been able to make the changes to the estate around the endoscopy suite. And a big thank you to all of the estates team that pulled out all the stops to make that happen in what is clearly challenging times. And finally, I think the one area that remains outstanding that's causing us a little bit of cause for concern is that we have a vacancy ongoing for the named doctor for safeguarding. And having spoken to Dave, I know he has plans to address this, and obviously the timing is a bit crucial, but we do have that vacancy at the moment, so we seek to get that addressed fairly swiftly, or as swiftly as we possibly can. Thank you.
Any questions? Well, it's really good news on the endoscopy, isn't it? Excellent news, that is. And Dave, do you have any idea on the sort of likely timescale for the safeguarding, or are you still trying to work it out?
John, I think Dave has just dropped off to join the weekly JDF with the junior doctors.
Oh, fair enough. Okay. All right.
Yeah,
well, perhaps. Sorry, Julius.
I think I can answer this because I've been working closely with Dave on it. We're just looking at the job description, the PAs available, because when we advertised it, it wasn't attractive, right. And we're just revising that. So I think in the next 4 weeks it'll be out again, and we just need to encourage some people to apply, I think.
Okay, good. Thank you. Okay, thanks. And finally, the People Committee. Ranjit.
Thank you, John. Sorry, my camera doesn't work. Again, I'll take the report as read. I think the key things I wanted to say was our focus, understandably, was on the BAF framework review and our reviewing our risks. We also agreed as further action, we'd take another deeper dive into the sickness absence figures and look at those at future committees. We also got further assurance on the bullying and harassment action plans, which are a priority. And then moving on positively, we're always asking about impact and assurance of impact on the various controls and measures we take. And the staff survey, whilst embargo, we got some headline figures, and it was really positive to see significant improvements in many areas, particularly the impact of the well-being. So that's my main update, and I'll take any questions. Thanks. Is that okay, John?
Yep, I'm just looking to see if there are any questions. Can't see any. So that's lovely. Thank you, Manjeet.
Thank you.
Barbara, I just realised we didn't mention under the quality annual report. Do you want to say anything about that, or is that just to note?
Apologies, Chair. I completely forgot about that too. So sorry. It is to note, unless, of course, anyone wishes to ask any questions. Thank you.
Okay, thank you. Right, communications to the wider organisation. I mean, I've got 3 or 4, but Laura, if you've got any you want to add, please say. I mean, I think we might just reflect on the COVID in its wider sense. And secondly, the work that's going on in maternity, because I think that's really important as well. Staff welfare, I think, is a theme we should keep going. I think we should reflect on the performance at a relatively high level and note actually that we are keeping a number of services going which we didn't before, and particularly those priority ones, and that there is a prioritisation process. I think some of that would be useful. Is there anything else people think we should add to the report on that? Sorry? Freedom to speak up, we ought to say as well, yeah. Richard, anything you can want to add to that?
Just thinking, and Lorna and I swapped a message earlier, I think it would be opportune to reference the, I think I said it was £112,000 of the Captain Tom Moore money and how we're spending it.
Yeah, I think that would be good, yeah. Yeah, thank you. Okay, good, thank you for that. I haven't been notified of any other business, so I'm going to declare the meeting closed, public meeting. Have we had any questions from the public? I don't think so, but...
No, Chair.
Okay, thank you. In that case, thank you very much. I'll end the meeting. Can I suggest, because I think Richard and Paul have to go on a IOCS meeting, could we start the private at 22? So 10 minutes late, I think it is, isn't it? Instead of 1:30, 20 to 2. Is that okay?
That'd be great, thank you.
Thank you very much.
Thank you.
Thanks, bye.